My name's Kiran. I'm an ENT surgeon out in Surrey. I'm also the ENT clinical lead for the South Thames Peds Network. And really, this webinar is to go through our recent update to guidelines for tonsillectomy. To go through the guidelines, we'll also discuss some of the rationale for it and also answer any questions anyone may have regarding its implementation. So as you all know, tonsillectomy is probably one of the most commonly performed procedures that we do. It's generally a very safe and effective procedure in kids, and broadly across the country, it's largely performed as day case surgery. And there are, of course, some children where you admit, particularly the more complex ones, but it's largely a day case operation. Now, there are some risks for tonsillectomy in children, and some of these are serious. So things like bleeding. Children are sometimes readmitted with pain, and in children with sleep apnea, you can get a worsening of the breathing following the surgery. But thankfully, these complications are relatively low. In terms of indications for tonsillectomy, the two most common things that you're going to see in most hospitals is recurrent tonsillitis or sleep apnea. There are some other niche indications. So histology, that's where you're trying to get a sample of one of the tonsils because it looks abnormal or you're worried about cancer. And there's other conditions such as PFAPA and guttate psoriasis, but these are sort of rarer things really. So the most children are going to be getting them out for recurrent tonsillitis and sleep apnea. So part of this guidance is really to mitigate complications afterwards. And the one thing we sort of worry about is readmission, and that's generally for pain or bleeding. A small proportion of children unfortunately do return to the operating theatre to stop bleeding. And as you can imagine, in a small child with not a large volume of blood, that's the one we all worry about really. There's also other minor complications that occur from tonsillectomy, but really we're talking about readmission here, largely from pain and bleeding. In terms of current guidelines for practice, within our region, the regional guidelines are, of course, the STPN guidance, which I'm talking about today, but there is also a BAPO day case tonsillectomy guidelines that was published similar time to our STPN guidance, so that's well worth a view as well. There are some differences between the two, and I'll come on to that in a second. So in terms of treatment location, the vast majority of these children should be able to have their surgery within the DGH environment. Now, some of them will need to be referred to tertiary centres, particularly smaller or younger children, and those with more significant comorbidities. You may have seen these guidelines already. This table was present in the previous guidance as well, but essentially we stratify children into three cohorts. Low risk, medium risk, and high risk. Now, from our STPN point of view, low risk is a child that's 2 or older, above 12 kilos, and generally with no high risk factors. So normal BMI, no comorbidities, and mild to moderate OSA. And these should be able to be done in any secondary care centre. Medium risk children are those that are a little bit smaller, so 1 to 2, between sort of 10 to 12 kilos. Again, no high risk factors, but may have clinically more severe sleep apnea, and these can be done within the secondary care environment, providing you've got a HDU just as a backup essentially. And finally, the high risk cases. Now, these are going to represent a very small proportion of tonsillectomies that are done within the UK, but essentially these are children with significant comorbidities, so BMI extremes, syndromes, neuromuscular disorders, and so on. There's obviously a whole list of these things, cardiac and respiratory issues as well. And these children are more appropriately done in a tertiary centre. But the vast majority of children are going to fall into this category, with a small proportion and sort of medium proportion of this category and a very small proportion in the high risk. So most of these can be done in a DGH setting. I just wanted to talk a little bit about the evolution of the weight and age criteria, because I'm sure many of you have seen the guidelines change over the last 10 to 20 years. And it's just interesting to see how that's evolved, really. So around 2009, Mr. Robb and others set out some guidance, and the consensus at that time was that if you're less than 15 kilos and less than 2, you should be done in a tertiary centre. Fast forward 11 years, BAPO then came out with slightly more modified guidelines based on various bits of evidence and looking at complication rates in different ages and so on. And their feeling was that if you were 2 or older and 12 kilos or more, you were suitable for a DGH, providing you didn't have any of the high risk factors, which we've already spoken about. and those are a little bit smaller would be suitable for a DGH with a HDU. And the STPN guidance at this time mirrored this as well. Now, very recently, BAPO have come up with a further consensus guideline. I should sort of let you know, BAPO is our paediatric ENT organisation for the country. That's the British Association of Paediatric Otolaryngologists. So BAPO in 2024 adjusted these guidelines slightly and have said that if you're 3 or older or 14 kilos or more, you're suitable for DGH, day case surgery. And if you fall slightly short of this, so between 2 and 3 and between 12 to 14 kilos, you should only really consider day case if you have a level 2 HDU. Now, our guidelines actually, slight discrepancy. We felt that we should stick to what we've already been doing within our network. So our guideline remains the same. I'll come on to the rationale for this in the next slide. As we mentioned, pre the 2020 guidelines, less than 15 kilos wasn't suitable for days sort of secondary care centres, which is tricky because actually the 15 kilos is the average weight of a 3.5-year-old. So what's happened is probably a lot of children that could be done in the DGH environment prior to this was sent up to tertiary centres. And the pressures were immense on tertiary centres before, but obviously with COVID and all the backlogs with kids, it's even more so now. So that obviously needed to be adjusted, and hence why BAPO adjusted it a few years ago. And the STPN agreed with this, and essentially within our region, all the surgeons follow these guidelines and have done so for the last 4 years with minimal issues. The BAPO guidelines, and the reason for the change of it is largely to empower day case surgery across the country. Now, outside of our network, there are plenty of places in the UK where day surgery is still not the done thing. So a lot of children are admitted overnight, even despite not needing it. And part of making these criteria slightly more conservative was to sort of empower these units to do more day case surgery. We then had a consensus discussion within our own network, and most departments were very happy with the old criteria and had the data to back it up. And so we agreed that we should continue the 12 kilos and 2 years old for day case surgery, providing they're not high risk, essentially. I then had a discussion at BAPO, with BAPO recently as well, who fully supported our stance and were happy for us to have our own regional guidelines based upon our local practice. And that's the reason why we've kept with what we've agreed a few years ago as well. Pre-assessment is absolutely essential. It's, as with a lot of things with children, this has taken a major hit following COVID. So there's many units who unfortunately don't have an efficient pre-assessment service, and it's a lot of work. We're in my local hospital in Ashford St Peters. We've had to put a lot of work into setting up resetting up a pre-assessment service. But essentially, our feeling is that children going tonsillectomy should be seen with a face-to-face pre-assessment, reviewing medical history and their overall health, especially those with sleep apnea, because it allows you to stratify risk. And pre-assessment is also essential in preparing the children from a sort of psychological aspect for the day of surgery. I won't go into too much detail on pre-assessment, but there is an excellent page on the STPN network website which goes through guidelines, and there's lots of resources on there to support your units in developing these services. I think the surgical techniques, I think it's really important, really, because things have changed a lot in the last few years. I'll show you a picture on the next page, which will cover this in a bit more clearer detail. But essentially, there's 2 ways to do a tonsillectomy. Your tonsil itself is a little bit like a fruit. It's got a peel on one side and the tonsils on the other side, and the peel protects the tonsil from the muscle. And I'll show you this in the next page. But essentially, traditionally, or years ago, we used to take the entire tonsil out, including that peel, which is called the capsule, and that meant that the muscle is exposed. You damage the muscle underneath, which causes more pain. But we also know that the bigger blood vessels sit in that muscle, so the risk of bleeding is also theoretically higher. Now, in the last sort of few years, what's gained popularity is what we call an intracapsular tonsillectomy, and that's where you remove the majority of the tonsil, but you don't take the capsule away, and that protects the muscle underneath. So theoretically, that reduces the risk of bleeding and pain, which is great in terms of driving day case rates, but also preventing readmission. These have various names. So an extracapsular tonsillectomy is where you take the whole tonsil out, but you might see this described as cold steel or bipolar diathermy, and that's just the way you take the tonsil out. They're essentially the same thing. An intracapsular tonsillectomy is where you're taking most of the tonsil away, but leaving a little bit behind. This as well has different techniques. The one most of you will be familiar with is something called coblation, which is essentially using something called radio frequency ablation to melt the tonsil tissue away. And that's probably the gold standard for the intracapsular technique. But you can use a microdebrider as well, although that's not commonly done. This is just a picture of what I've described, really. So picture of the oral cavity, you can see both tonsils there. So your tonsils, this purple bit here, there is something called a capsule that separates the tonsil from the muscle underneath. And when we're talking about an extracapsular tonsillectomy, we're taking the whole tonsil and the capsule away. So it's like this, and you're exposing that muscle there. That muscle will be bruised, so it's painful, as we've said already. And then there's bigger blood vessels that sit in there as well. So theoretically, the risk of bleeding goes up with this. Now, with an intracapsular tonsillectomy, you're using a special wand to take away all the purple tonsil tissue, but leaving behind that capsule, which protects the muscles we discussed already. So on paper should reduce the risk of bleeding and pain. So this has gained a lot of popularity in recent times, and you know, based on lots of discussions we've had in the STPN, lots of people are using coblation to do this within our region, which is great. In terms of comparison of techniques, there's generally very good data that extracapsular, that's where you're taking the whole tonsil and capsule out, is generally more painful after the operation and carries a risk of bleeding that's higher. If we look at the Get It Right First Time data, big audit that we did recently across the country, bleeding rates are significantly higher in extracapsular versus intracapsular. So 2.9% versus 0.7%, and those are the best performing units. But even in the upper outliers, it's still better. So 9% bleeding rate for extracapsular and 7.2% for intracapsular. There's really good evidence that it's much less painful, and kids are often back to school within the first week and sometimes earlier, which is great for the parents. The only slight trade-off is because you're not taking the entire tonsil out, there's theoretically a risk of regrowth of the tonsil, and that's much more common in children less than 3, or that the little bit of tonsil tissue you leave behind causes an issue in the future, and that means a child might need more surgery. And those rates vary. It's somewhere between 1% to 5%. It's probably a little bit higher in children less than 3. But I suppose the question here is, would you trade off having a much lower risk of bleeding versus having to come back to have a small controlled procedure? And I think most parents would probably prefer the latter. So from our stance point, definitely it's something that units should try and offer if they can. In terms of post-op management, children undergoing tonsillectomy can be booked onto both morning and afternoon ENT theatre sessions, and day case can still be facilitated even in afternoon sessions, and that's partly because of the discharge timing recommendations that we've now adjusted to. Most of you probably do this in the morning, which makes it a bit easier, but certainly there's no reason why cases can't be done in the afternoon. We recommend a minimum stay of 3 hours, and that's mirrored by ENT UK guidelines as well as BAPO guidance, but a minimum of 3 really, not the 6 that it used to be, which I'll come on to, and that's from when the child leaves theatre essentially. In terms of post-operative observation, you're going to need to keep an eye on these kids for at least 3 hours after surgery, monitoring oral intake and of course monitoring for signs of bleeding. This is our recommended discharge list. So an early warning score or equivalent score of 0 on discharge. You want their pain to be controlled with simple painkillers and not opiates, essentially. And you want them to be eating and drinking afterwards. Clearly, you wouldn't want them vomiting from the effects of the anaesthetic, and things like bleeding and oxygen requirement are a must to be controlled prior to discharge. And you also need to be confident that the parents can continue the observations at home, and of course they need to be up and about. Discharge times have evolved a lot again in the last 10 years. We've always been on a 6-hour discharge, and it was quite an arbitrary number, and there's no real strong evidence base for that, but it's been widely practiced across the country for many years. Now, with the advent of intracapsular tonsillectomy, we know that pain, bleeding and readmission rates are far less than before. But even with extracapsular, actually most of these children are fine to go home in 3 to 4 hours, and that's our stance essentially. We would aim for 3 to 4 hours where possible. Obviously in some children you can't do that, but the vast majority you should be able to. Analgesia. So ideally, we would like to promote weight-based analgesia. The bottles are great, but not every child's the same. You know, some kids are going to be bigger, some kids are going to be smaller, and you really want to make sure that they're given the adequate amount of analgesia, because if they're not, then obviously there's a small risk of them coming back to get more analgesia in it as a readmission. And our suggestion is that you go for at least 15 milligrams per kilogram in divided doses for paracetamol, and consider up to 80 milligrams 4 times a day if need be. And similarly, ibuprofen, a minimum of 7.5 milligrams a kilogram 3 times a day, and up to 10 milligrams if needed. Oral morph is variably prescribed across the region, but it's a completely reasonable rescue analgesic option on a case-by-case basis. I think this will tend to be generally older children. Once they reach their teen years, the complication rates do go up a little bit more, and it's a much more painful operation compared to young kids. And clearly you have to take into account patient factors, family factors, and so on when you're prescribing opiate analgesia. But if you give them a few doses post-operatively, it may prevent a readmission. And I think parents just need to be educated on the side effects and the fact that if they're going to be giving a few doses in a day, it might be worthwhile them touching base with someone, essentially the ward, just to see if they can get any advice. The other thing that's great is Diflam spray or mouthwash. So Diflam's the trade name, but it's called benzidamine. But this is an antiseptic anesthetic spray that you can use every hour and a half to 3 hours, and it gets right to the site of the pain, so it works really, really well. Now, we've suggested that we should consider a minimum of 5 to 7 days of analgesia, but you can give it up to 14 days. There's considerable variation in practice across the region. Clearly, patients undergoing coblation or intracapsular tonsillectomy will require far less analgesia, and the ones going in extracapsular may need it for longer. But it's really on a case-by-case basis. But I think the important thing here is the weight-based analgesia, regardless of technique, and I think that will hopefully help prevent readmissions for pain. This was actually flagged up by one of my colleagues who works in an area where there's perhaps slightly more deprived families, and the question is, you know, do you just prescribe and give the analgesia to the parents rather than parents purchasing it? Because there are some places across the deanery where, sadly, you know, people may not be able to afford things, or they may forego certain things, and that would be pretty sad if that sort of results in a readmission. And analgesia is generally quite cheap. Clearly, this is going to be variable across the region. Some hospitals may not fund this, but where possible, we are suggesting that if you can give the parents the analgesia, it'll make things a lot easier. I think it's really important to try and gain post-op pain feedback from parents and children to help audit, but also if you had a way of monitoring it in the immediate recovery period, it might prevent a readmission. And you need to give parents clear instructions to highlight the important of regular analgesia and timing and schedules, because again, there's obviously a sort of art to this in terms of getting analgesia under control. So these are some of the common questions that people get asked, really, and we had a discussion again within our network meeting to see what everyone does. So when can the child return to normal activities or school or nursery? Again, there's considerable variation across the network. There is probably some dependence on the technique. So people often feel that extracapsular tonsillectomy children may need to go back later, whereas intracapsular they go back sooner. But broadly, between 7 to 14 days is the general benchmark, and I think that's what you should aim for if you can. When can a child go on a plane or go on a long distance journey? We felt that 3 weeks was probably the safe option, just because there is a very low risk of a bleed within the 3rd week. But obviously, if you're on a plane 10,000 feet in the air, that would obviously present lots of other issues. So I think 3 weeks is what we felt was a safe minimum amount. In terms of other considerations, avoiding smoky environments, advice on when to come back to A&E. I mean, this is largely going to be bleeding and pain, but obviously there's other scenarios as well where parents might need to come back. And I think it's important to have a contact point that parents have in case there is a complication. And clearly within the initial period, perhaps avoiding contact with those with coughs and colds where feasible, but that's not always possible, of course. In terms of follow-up, most of these kids should just be discharged, really. The vast majority of them get better. There are going to be some cases that are a little bit more complicated where you may need to see them again. This includes cases where you've sent the tonsils off to the lab to check for cancer, or there might be some children who have severe sleep apnea with loads of other comorbidities. In that sort of case, you might want to see them again. But most otherwise well normal children should just be discharged post-operatively. So that's really a summary of everything. So what next, really? I mean, we're hoping to audit our practice within the network to see what everyone's doing, to see if everyone's adjusting their practice and guidelines, and really looking to see what the outcomes are of this, really. We'll hopefully be sending out a few surveys further down the line this year to facilitate that. And that's it, really. Any questions?